Hello everyone. My name is Mohammed Benhawi, admin of ENT, Egyptian ENT Forum. Today we will have a rhinology lecture with international speaker Professor Flavio Nogueira from Mexique, and he will talk about Choanal Atresia. Let me and my friend Dr. Tamer, one of the admin of Egyptian ENT, welcome Dr. Flavio. Hello, Dr. Tamer.
Hello, everyone. Good evening and good morning, wherever you are, and whatever the time you have. Today, really, we are very lucky to have an international figure, a friend, a teacher, and a very informative person. I know him from a long time ago, maybe 4 or 5 years before. We met before in Italy, and we met in Boston the last time. He's very international figure. He is very talented, still young, but still have a very good experience. Prof. Flavio from Brazil. He's a sionistic person. He in fan with endoscopic ear surgery. He published in the last 5 years around 28 or 29 international publication. One of the most important is the management of glomus tympanicum using the endoscopic ear surgery. Today, maybe we choose a different field that he fan of, but he still liked the Choanal Atresia. And really, we are very lucky to receive his presentation today. And he was very sionistic and he was very active to share with us his experience. Thank you, Prof. Flavio. You can hear us?
Yes, I can hear you very well. And thank you very much for this very good invitation.
Appreciating your effort, appreciating your time, and make sure that all Egyptian fellows and all over the Arab region, we are waiting for your presentation today. I try to post the link wherever I can in order to give the chance for all the people all over the globe in order to follow your presentation. You can start your presentation and we are following for 1 hour, and after we finish, we're going to start the questionnaire. So thank you for your time, thank you for your effort, and we are waiting for your presentation.
Thank you. So let's start with no delays.
Okay.
Can you see the presentation?
Yeah.
Okay.
So
okay. So first of all, it's a great honor to me and a great pleasure to talk to my friends in Egypt, especially, and all over the world, using this forum, this Egyptian ENT forum, which is very, very informative and very nice. So I'll try to talk a little bit about the endoscopic management of the choanal atresia, which is a thing relatively common here in Brazil. So I'm very honored and I'm very happy for this invitation and this opportunity to talk about any kind of sinus surgery. So this is a QR code. If you take a picture of this QR code, if you put your camera pointing to this QR code, you're going to be redirected to my YouTube channel, where you can see all the surgical videos that I present on this presentation. Some of them are narrated with English, some of them are not, but you can also download the videos, and then this is my email. You can contact me if you have any questions or any doubts. I come from a city called Fortaleza, which is located in the northeast part of Brazil. As you know, Brazil now is one of the epicenters of the COVID-19 pandemic in the world. But since we were one of the last continents in the world to have this disease, this pandemic, we kind of prepare ourselves. Of course, we have crazy politicians as our crazy president, but it's another story. So I hope we can deal with this pandemic in a very good way. And I hope we can win. This is a picture of our friend, Dr. Daniele Marchioni from Italy, which was very bad hit by the COVID-19. And I hope we can overcome this pandemic, and then in the near future we can all meet together in one of the congresses throughout the world. So it's my dream, and I hope. And you know, I like history very well, very much. And if you compare the Spanish flu with this COVID-19 pandemic, Spanish flu being the worst pandemic in the last century, and Spanish flu is a wrong name, of course. It was originated in Kansas, in the USA, the influenza virus that caused the Spanish flu. It got its name, Spanish flu, because since they were still at World War I, the press in several countries, just like US or England or France or Germany, the press was controlled by the government. So in order to not to lower down the morale of the troops, the press did not talk about any flu or any disease or any pandemic. And Spain was not in the war. And the Spanish king, Alfonso XIII, got the disease. He was not killed by the disease, but he got the disease. And because the Spanish press was not controlled, was a free press at the time, they all put on the papers, and the whole world knew the pandemic as the Spanish flu or the Spanish pandemic. But of course, you can have several things that we can compare to the Spanish flu to the COVID-19. First of all, the denial. Many people denied the disease existed. And second of all, the preparing of the health system, the quarantines, the lockouts, the lockdowns, and all the stuff like that. Rio was the capital city of Brazil. And just like at the time of the Spanish flu, where the most important cities that were hit in Brazil were like the seaport regions like Rio, Recife, Fortaleza, Salvador. Nowadays, the most hit cities in Brazil, as we speak, are the cities with the biggest international airports. So Sao Paulo, Rio de Janeiro, Fortaleza, Manaus, Recife, Brasilia, and all these cities, we are in the center of this hurricane, of this typhoon. But I hope we can overcome this disease. So this is a video that I always like to show of Dr. Julius Lempert. Professor Julius Lempert is considered to be the father of modern otology. But here we can see him operating a nose, a septoplasty, local anesthesia with cocaine, no general anesthesia whatsoever, no endoscopes, no loops, no microscopes, just like a frontal mirror, and no gloves. Of course, they didn't believe in viruses or bacteria or whatever. So, of course, this cannot be done anymore like this. And it was an office-based procedure. As you can see, he would perform very fast the septoplasty in a way that many people cannot perform nowadays. He would use this instrument, which is called the Ballinger knife, which is an old instrument that people used to do to cut the cartilage and then to remove the quadrangular cartilage of the nose. And then he would put a little bit more of cocaine, remove the cartilage. Probably the patient was very happy. And then he would not use any special instruments, just like coblation or shavers or microdebriders or HD cameras or whatever instruments nowadays we use that can overcome the price of the procedure, of course. And then he would remove the vomer and the perpendicular plate of the ethmoid bone. And then at the end, just a towel, no packing, and then next customer, please. So it was a very fast procedure in a very good way that he could perform. But if we look at the papers at the time, that video was from the 1920s, but if you look at the papers, these are Brazilian papers from 1918, from October of 1918, we can see the same questions people, the humans, asked about the COVID, the Spanish flu, and that we are asking about the COVID-19. So where did it start? Is quarantine a good solution? Do we have any medications for it? Can we overcome this? How many people are going to die? Or when are we going to get back to normal? So these were questions that were asked. And of course, with time, and giving a spoiler, of course, we did overcome the Spanish flu, but the world was definitely different from the world that we entered the Spanish flu. So 1920 was definitely different from 1918, for better or for worse. So this is a picture of the hospital that I work, the Hospital São Carlos. And this picture I always put on those lectures, on those days of webinars, to remind us that we must be protected. We as ENTs, we are like in the front line of seeing COVID patients, seeing patients with flu that can have similar symptoms as a COVID-19. So we have to protect ourselves. If we think about in China or even in Europe, one of the most hit professionals, medical professionals, were the ENTs. The ENTs and the ophthalmologists, because we do exams in the area that the virus is more prone to be, just like the rhinopharynx or the oral cavity. So we are soldiers, and any soldier that go to war has to protect itself. If you do not protect yourself, you can have problems. And of course, protection is masks, gowns, gloves, goggles, everything that you need, all the protective device that you can use in order to have the protection. And one of the most important protections nowadays, I think, since we are in the era of knowledge and the era of fast information, and some of those fast information can be fake news, one of the most important protections is the ear mask. Of course, it's a virtual mask, but you have to protect yourself against bad information, because sometimes it's good that we live in an era of fast information, but sometimes, unfortunately, some of this information that is passed, especially through social media or to WhatsApp groups, unfortunately, some of those informations are fake news or fake information that can not help the procedure. And I like to call that nowadays we have a lot of specialists, a very fast formed specialists on empirical knowledge formed by the WhatsApp University. So you have to wear those masks, but you have to protect yourself. Protect with face masks, goggles, masks, 2 masks sometimes, and not like this, using like this X-ray face shield. You have to protect yourself in a very good way to try to fight this war against the COVID-19 with all the masks, all the devices. Of course, I am a Star Wars fan, and you end up looking like Darth Vader. And if you think Darth Vader was like a visionary, because he had already his face mask with a ventilator. He wore gloves, gowns, and protective stuff, and everything else that he would need to kill the COVID-19. And of course, we can have Darth Vader on the OR, but not to kill ourselves or to destroy our surgical field. I will pass this fast. This COVID. Okay, but we're going to talk about the choanal atresia. So choanal atresia is a very interesting subject, because most of the patients that we are going to see are small children. And of course, it can be uni or bilateral. 60% or plus are unilateral. You can have more female babies than male babies. And of course, 30% is just a pure bony atresia, but 70% is like a kind of a mixed atresia, bony and mucosa, or mucosa and bony, and this is very important. So at those pictures here, you can see an atresia, unilateral atresia here, and here you can see a bilateral atresia. On those days, back like 10, 20 years ago, the surgical repair was very bad, because it was a very big surgery. You would do a transpalatal surgery through the mouth using the microscope or using the loupes, and then the surgery would be very big, with a big morbidity to the small patients. And of course, the results were not so good at the time. That's why many people are still afraid of doing choanal atresia surgery, because of the results of the past without the endoscopic area. The diagnosis is very important, and it's usually made at birth. At the time here in Brazil, every time we have a childbirth in any hospital here, the doctor has to try to pass a catheter through the nose all the way to the mouth of the patient to aspirate the secretions of the baby mouth and baby nose. And of course, if the catheter cannot go through the nose, probably they are going to suspect on choanal atresia, of course, if you have another signs, just as we are going to see later on. But of course, in the first days after the baby is born, you see a lot of intense respiratory distress. So you can do this diagnosis of the choanal atresia. And of course, we ask for imaging exams. First is endoscopy, nasal endoscopy, that even though the children is usually very small, within days of birth, you can put a small endoscope, rigid or even a flexible scope, to try to see the site of the atresia, or to try to see the atresia itself. And sometimes it is actually easier to do this endoscopy in a small baby, because sometimes the baby can be in an ICU unit and sedated, and so the baby is not going to move, and so it's going to be not very difficult. Otherwise, the size is going to be a limited factor. But you can ask for an imaging exam, just like a CT scan, which is nowadays the gold standard to identify and to see the size of the site of the choanal atresia. So we ask for a CT scan, paranasal sinus CT scan, and we ask for the axial cuts. The axial cuts, which is the main cut of the CT scan, can be very, very informative, and you can see different things. You can see the nasolacrimal duct to see if there are any malformations. You can see the nasal septum. You can see the inferior turbinates. You can see the septum. And then you can see the sinus, the maxillary sinus, if the maxillary sinus is big enough. And of course, you can see the site of the atresia, and if the atresia is more a bony atresia or more a mucosal atresia. So this is very important in order for you to prepare your surgical approach. Also, you can see if the atresia is unilateral, just like in this one, as we can see here, unilateral atresia, or bilateral atresia, if you can see here, the bilateral atresia in the patient. So the CT scan nowadays is the gold standard to try to identify. But also, those patients sometimes can have other malformations. Eye malformations, as a coloboma, heart defects, atresia, of course, retarded central nasal system growth, genitourinary abnormalities, and also ear malformations. So if you see a patient like this, you have to suspect of choanal atresia. And of course, this is very important also, because these patients usually they demand a lot of clinical treatments, of course, with pediatricians, with ICU intensivists, with radiologists to do all the diagnosis, with ophthalmologists. So it's a multidisciplinary team that we can use to try to treat those patients in order to get them a better quality of life. Of course, sometimes you ask for the CT scan and you see a thing like this with a kind of a defect in the skull base, in the anterior skull base. So you think about, oh, is it an atresia? Is it like an encephalocele? Is it like a brain inside the nose of the patient? But then when you have this doubt, you can ask for an MRI scan, and then you can see if there are brain content inside the nose, or it's just an atresia or secretions. And of course, this bony defect can be present without other malformations. And this is very important to see. So we talked about the diagnosis, the CT scans, and then what about the treatment? The treatment is 100% surgical. But of course, there is always the debate. Is it an emergency? It should be done under an emergency deal, or could we wait for a little bit in order to do the treatment? Of course, it always will depend on the problems of the patient. Sometimes most of the patients can have oral breathing. As you know, small babies, they rely on 100% nasal breathing in order not to swallow and not to have problems when they are breastfeeding. But some babies can tolerate very well kinds of pacifiers like this, or kinds of devices like this, in order that allow them to have a good respiration through the mouth. So we can have to see if the patient can tolerate this device, and sometimes you can wait a little bit in order to do the surgery. Of course, if the patient can support all this waiting, and then you can wait 30 days to 1 month, 2 months in order to do the procedures. But what about the techniques? There are several techniques about the closure or the opening of the choanal atresia. One of the techniques that I like and that I do very well is the crossover flap technique that was developed by Professor Schiller, Pignatari, and Professor Aldo Stam in Brazil. They published this. I helped the publication of another crossover flap that was done for septal perforations. But it's very clever technique, because one of the most common problems of this surgical procedure in the past, and that's why people used to use a lot of stents, is that small babies, they have a good healing most of the times. And since you are talking about a small cavity and you are doing like a 360-degree cruent area, you can have a lot of stenosis. So covering this exposed bone areas, or those areas that you cut with flaps, it's very clever. It's a very clever technique, just like the flaps that we can use for reconstruction of the anterior skull base. So they call the crossover technique, the crossover flap technique, and I will explain in some surgical videos later on. But one of the most important things is the instruments. Nowadays, we have different types of instruments that we can use that can help ourselves during the procedure. Most of the babies, most of the surgeries are done in small babies. In small babies, they have small nasal cavities. And of course, nowadays we have good endoscopes with 3mm diameter and 14 centimeters long from different companies that also have the wide angle view, and also the same prism that they have on the 4mm. So the 3mm is the same endoscope that we use on endoscopic ear surgery. And then you can use the 0, the 30-degree in order to perform the procedure. And as you're going to see in most of my videos, I also use ear instruments, round knives to elevate the flaps, ear suction devices, ear Bellucci scissors, ear freers, all ear instruments, ear curettes, even ear carries and punches. Since they are smaller, we use them in ear surgery, which is a small conduit that we have, and then they fit very well for choanal atresia patients, especially the smallest ones. So let's see some cases of choanal atresia. This is the first case, a 25-year-old boy, so a very small boy, and this boy was very important to me because he had also eye malformations. He didn't have the eyes. So as you can see, we are using the round knife and elevating the flaps with the round knife. This is the left side nasal cavity. This is in the center is the septum. This is the inferior turbinate. This is the middle turbinate. You gently can do some movements, and then you do basically a posterior septectomy. You remove the posterior part of the septum, sometimes a little bit of the cartilaginous part, but most of the bony part of the posterior septum. And then you create two flaps. One flap is going to be pediculated in the superior part, and the other flap is going to be pediculated in the inferior part. This is very important. One superior and another one inferior. So at the posterior part, you see this completely blockage, just this small hole, and then we need to open this completely blockage, inferior turbinate, and then we already did the flaps from both sides. One flap is pediculated here, another flap is pediculated here in the superior part. The left flap is pediculated in the superior part, and the right flap is pediculated in the inferior part. So we cut, as you can see, we are using a Bellucci scissor, a scissor to cut the mucosa part of the atresia. We can already see the rhinopharynx down there. You can use a small shaver if you want here to remove this part of this mucosa. If it's a big part of mucosa, you can try to use a shaver to remove. And then the goal here is to try to see with the endoscope in the same view different structures such as both eustachian tubes. So you can trim your flap according to the defect that you have. Of course, you have to open as much as you can, and to create this flap as the size that you want. And then that flap, that right flap, which is pediculated here, can be rotated to the other cavity to cover this bony defect that we created here, this exposed bone that we created here. And this other superior flap is going to be rotated to this side, to the right side, in order to cover any exposed bone here. Of course, you have to open as much as you can the cavity in order not to have problems with stenosis back again. Of course, in the superior part here, you have this sphenoid beak, and you have to take care without removing a lot of bone, because if you remove a lot of bone, you can enter the sphenoid sinus of this baby, and this is not going to be very, very good at this time. So the flap here, pediculated in the inferior part, is covering all the nasal floor here, including the exposed bone that we created, and the superior flap, which is pediculated here in the superior part, is going to be rotated to the other side. And of course, you have to trim the flap. Sometimes you can cut a little bit more, cut the flap more, to cover all the exposed area, cruent area, exposed area that you cut, in order to avoid any types of stenosis. Most of the times, we don't use any stents. Sometimes, when it's necessary, we use glue, fibrin glue, to hold the flaps in its position, and also a Foley catheter to try to hold the flaps in their position. So this was a very challenging surgery because it was less than 1 month year old child, so less than 30 days after born. And as you can see here in the CT scan, after you see the complete opening and you see the posterior septectomy, this was preoperative, this is postoperative, so in a very good way. Another example is this one, unilateral stenosis and bony stenosis, as you can see. So we always see the axial cuts here. There's sometimes secretions here at the site of the atresia. So in one side you see the secretions, and sometimes when you see those secretions, you see that there is an atresia. So the middle turbinate is here, the inferior turbinate is in the position, and the septum is here, and it's completely closed. Here, as you can see, the complete atresia at the right side of the nasal cavity. So we do the same. We test, we always inspect also the left side of the cavity to see if there is any obstruction. We see the adenoid tissue here. You see the eustachian tube in one side, and then you see the eustachian tube of the other side. And then you gently lateralize the inferior turbinates to create space for you to work and to create the flaps. Sometimes you can infiltrate with saline solution to hydrodissect the septum. In small babies, it's very difficult to infiltrate, and this infiltration can create problems of space. So I use this small cautery, monopolar cautery, to mark the regions of the flaps sometimes. So we mark the flaps in the one side, and then we mark the flaps in the left side. And then, as you can see, we are using ear round knife, the same instruments that we use to elevate the tympanomeatal flap. And then we elevate the flap, expose the bone, the posterior septal bone. We can use also cut scissors, Bellucci scissors. I like a lot Bellucci scissors to do this cutting, because the Bellucci scissor is very sharp scissor. And then one flap, as you can see, is pediculated in the most inferior part, and the other flap is pediculated in the most superior part. That's why we call the crossover technique. So the left side flap, in this case, is pediculated down, and then the right side flap is pediculated up. So I'm cutting here the left side flap, cutting the upper part, but it's pediculated here, down here. And the septum is still here. We're removing the septum, doing the posterior septectomy, and then removing all this cartilage and this bone. Sometimes we remove more bone, sometimes a little bit of cartilage. And then using this Garrison punch, we can communicate from the left side to the right side. So one flap, as you recall, is pediculated down, and the other one is pediculated up. So we open, create a big opening. We are using ear instruments, ear suction devices. And then at the end, this flap, the left side flap, which was pediculated down, is rotated to the right side. We can see the adenoid tissue, and we can see the eustachian tube here, both eustachian tubes. Since it's children, sometimes the adenoid is sometimes a big adenoid. So we see the eustachian tube from the left side and from the right side. And then we can do the pediculation and the rotation of the flap, the superior flap from one side to the other side, and the inferior flap from one side to the other side. So this flap, the left side flap, was pediculated inferior. We rotate to the right side. And the right side flap, which was pediculated superior, we rotate to the left side. So we can have all the areas here covered. And see, in this case, we didn't use fibrin glue, but rather we used a Foley catheter in order to hold the flaps in its position. Another case, this case was bilateral, but this one, the left side had a small hole, a very small hole, that the child seemed to be using to do the respiration. Of course, was a very small. So secretions, when you see those secretions, it's very common to try to understand that you have a choanal atresia. So you have an atresia, a complete atresia in the right side, and then in the left side, you had the same atresia, but with a small, very small hole, as you can see here, a very small inferior hole. So you do the same thing. You lateralize the inferior turbinates. You do the infiltration whenever you can, to do the infiltration on both sides, to do hydrodissection in order for you to create the flaps. Sometimes you can infiltrate also the floor of the nasal cavity in order to have more room for elevation of the flaps. And I always like to mark the flaps using this cautery, this monopolar cautery. So we mark the flaps, and then from both sides, and then one of the flaps is going to be pediculated in the most superior part, and the other one is going to be pediculated in the most inferior part. Whatever you decide, but you must select. In this case here, as you can see, the right side flap is going to be pediculated in the superior part. So I'll cut here the inferior part. And then the left side flap is going to be pediculated in the inferior part, and then I cut the superior part. So, but you can choose these pediculations according to your preference, as long as you have two different sides of pediculations of flap. So here we can see the end of this pediculated here in the superior part, and then you can see the end and the region of the atresia. So in the other side we do the same, but as you remember, that flap was pediculated in the superior part. So this flap is going to be pediculated in the inferior part. So we will cut here the superior end of this flap. So we are cutting here the superior end. As you can see, we're using Bellucci scissors, ear instruments to perform nasal surgery. So now we can use chisels and hammers, or you can use drills, or you can use piezo, and then you open the atresia, the area of the atresia. And of course, you have always to take care not to open the sphenoid sinus in the most superior part. You can use Garrison punches. And as you can see, I am with a good assistant here, and I am using one side of the nasal cavity as my conduit, and the other side as the assistant's conduit. So at the end, you rotate the flap, the inferior pediculated flap, to the right side, and the superior pediculated flap to the left side. So this is the left side flap being rotated to the right side, and now the right side flap being rotated to the left side. Sometimes if the flap is big, you can cut the flap, and then you can throw away that mucosa and then rotate the other part of the mucosa, covering all the bony defect and all the bony exposed bone or exposed mucosa or cut mucosa that you create. And then at the end, you can cover all the bony defects, or the exposed bone that you have, and you can reposition the flaps to completely cover all the bone and not having any exposed area in order to complicate the healing process of the nasal cavity. As we can talk, we are talking about children. So those children, they have a very strong recovery or a very strong cicatrization process, and this can close. Sometimes you can put some hemostatic material, just like this one, to hold the flaps. I use in this case fibrin glue, also to hold the flaps. It's important for the fibrin glue not to close again the cavity, because sometimes the fibrin glue can also create like a tissue, a pathway for the cicatrization and for the stenosis again. Another example of this one, it's unilateral choanal atresia. And as you can see, it's the same techniques. I always like to repeat for you to understand the technique, the crossover technique, putting one flap pediculated in one side and another flap pediculated in another side, and also inferior and superior. So we do the same. We mark the flaps here. One is going to be pediculated in the superior part, and the other one is going to be pediculated in the inferior part. So the right side flap, in this case, is going to be pediculated in the superior part. As you can see, I'm using also an ear instrument, and this is a suction elevator round knife that we can have for endoscopic ear surgery, and we can use in sinus surgery in this kind of procedures, for instance. And then we can use cottonoids, adrenaline soak cottonoids. The same techniques that we use on ear surgery, we can use also in sinus surgery. And this is a surgery that you have to be very delicate because the space is very small, and then you have to work in a very closed condition. So we are creating the other side of flap and then cutting here to have exposed the other side and to remove this bone. Is a posterior septectomy that we are creating here. So it's going to be a very good way to perform this surgery. You remove the posterior part of the septum, and then you expose here. You have to see both eustachian tube orifices, and of course you have to create this cavity and put one flap to one side and the other flap to the other side in a condition that you can see and you can create space. And as you can see, we can see the eustachian tube from this side, the eustachian tube from the other side, a good space created, no exposed bone here, covered by the flaps, also no exposed cruent area here, covered by the flaps, also fibrin glue at the end. And then we can put sometimes a Foley catheter, a balloon catheter, to try to hold the flaps in its position. This Foley catheter stays for about 1 or 2 days. We fill up with a saline solution, sometimes 1 ml, 2 ml, or 3 ml. It will depend on the size of the patient. And of course, with 1 or 2 days, we remove this catheter, the Foley catheter. Another case, and it's the same. Always we do in the same way. You can see a lot of secretions. And the most important thing is to have the correct instruments, small instruments. This is very important. That's why I like to use ear instruments in order to perform this kind of choanal atresia surgery. So you do the same. You create the flaps. One is going to be pediculated in the superior part. The other one is going to be pediculated in the inferior part. As you can see, we are using ear instruments. And then at the end, you will rotate the flap, and then we'll have a very good surgery in a very good way in order to do this procedure. So I will, just for the sake of time, I will put in a fast mode here, just for you to see the final aspect of the choanal atresia here, the flaps here, pediculated from the right side to the left side, and then from the left side to the right side, rotated in this crossover way that we can do. And then at the end, you have a good opening, and then we put all the material, necessary material, to try to hold the flaps in position. It can be a catheter, glue, fibrin glue, and whatever we can use to hold those flaps in position. So it's another case, but I will pass here. Another case I will pass because of time. And this is important because it's the post-operative. And as you will see, this is a bigger child that we did the surgery when this child was like 3 months old, and now he is about 3 years old. And as we can see, it's already completely healed. A little bit of adenoids hypertrophy, but it's a good way to heal. And you see the flaps, and you see the completely septectomy, the posterior septectomy, and the healing of this atresia of the patient in the postoperative. So in summary, endoscopy and CTs are the methods of choice for the diagnosis, especially the axial cuts. Nowadays, the endoscopic transnasal surgery is the gold standard for the treatment of choanal atresia. Of course, you have to understand the clinical conditions of the patient. You have to have a multidisciplinary team in order to work with those children, because sometimes they have another kinds of malformations. To use ear instruments and ear endoscopes, for me, is paramount. It's very, very well recommended because it's a small cavity most of the times in children, and this is very important. And this technique, the crossover flap technique, I think it reduces, and all the papers they show that, the incidence of rare stenosis and the need of stents. Of course, we use a kind of a stent, which is the Foley catheter sometimes, but no traditional stents that we have to remove under endoscopy, or drug-eluting stents, or mitomycin, or whatever that people like to use. This was a drawing, but this is another paper by Dr. Sedin, which was his PhD thesis, talking about a flap technique, but not crossover. This is parallel. So as you can see, there are a lot of techniques, but I like very much the crossover technique. So I think that was it, and we talked about like 40 minutes or so, and let's hope to answer some questions. And obrigado is thank you very much for your attention, and I hope you had understand the technique, and I hope you could understand the way we deal with the crossover technique, which is the same technique that we use for perforations, for nasal septum perforations. Is the same technique that we use also from Professor Achille Pignatari here from Brazil. So do you have any questions?
Hello, Professor Flavio.
Yes.
Thanks for your nice lecture, and the video surgery is very, very interesting. And thanks for your time again. So we will shift to the second part of the lecture, answering the questions from our colleagues. Okay?
Yes.
So I'll give you the first question here. Okay.
The question is, what is laboratory investigations for these cases, and what is the best time for unilateral type of operation? So this is a very nice question. The first part of the question is laboratory investigations. You should do all the laboratory investigations as you do for preoperative assessment of any patient. Of course, you have to talk with the ICU specialist and the pediatrician to see if the patient has some kinds of problems, like heart problems or liver problems or kidney problems. And according to these problems, you will ask for laboratory exams to see if the patient has conditions to go under general anesthesia. And what's the time for unilateral operation? For me, unilateral operation is best because, of course, you can delay a little bit more. You can wait for the children to get more facial growth. So up to 3-4 months, unilateral is a good time to wait, and the children has already a good space of course, if you use ear instruments. If you're going to use traditional sinus instruments, sometimes you can wait a little bit more, 6, 8, 9, or even 1 year to do the operation for unilateral. But I think doing in the early stage is sometimes good if you use ear instruments, and using this technique is a very good way to do the surgery. So the question is, thanks, Dr. João Flávio Nogueira, for this wonderful presentations. Do you sometimes use drills to remove the vomer, or do you prefer the Carrison forceps? This is a very important question. I, especially in small children, don't like to use drills. Why? Because the drills sometimes they can, with the rotation of the drills, can hit the mucosa and create more acute area, more bleeding area, and this area is going to have fibrosis, and sometimes this fibrosis can generate scar tissues that can close again. So anytime I can, I avoid to use the drills in those kinds of children, but I like to use the Carrison forceps because I think the Carrison forceps gives you a more clean cut, a more mucosal and bone clean cut, and the bone is not that thick that in that region that you need to use a drill if it's a small baby. So I like to use the Carrison punch, and also sometimes the chisels and the hammers to do clean cuts, not to use the drills. Sometimes the drill with the rotation can injure a mucosa or bone, and then this can create more scar tissue that can provoke more stenosis. So another question is flaps. Is it a rule for all cases? Yes. I always like to use flaps. Why? Because when you cover this accruent area with flaps, and the flaps are with a normal mucosa, you can reduce the possibility of crusts and reduce the possibility of stenosis because you don't have a lot of scar tissue when you use the flaps with a normal mucosa. So yes, I do in all, it's a rule for me in all cases, the flaps, the crossover techniques with the flaps. So another question is, what is your extent of the posterior septectomy? Does that affect ossification centers in the septum? This is a good question. Well, we remove the vomer, basically the vomer, which is down, and sometimes a little bit of the perpendicular plate of the ethmoid bone. Sometimes we go anterior to the cartilage, but just a little bit of the cartilage in the transition between the cartilage and the bony septum. And of course, the nasal, the structure of the nose is not going to be affected because the supporting part of the structure of the nose and the shape of the nose is defined by the anterior part. The anterior part we don't even touch. So this does not affect any kind of ossification of the septum, and we don't have any problems with malformations or deformations of the nasal of the children. Another question is from my friend Tamir. In your valuable experience, what are points to be considered to minimize the risk of recurrence? This is very important. First of all, to have a good exposure at the end. What is a good exposure? You have to see all the rhinopharynx, adenoid tissue, and both eustachian tubes with the endoscope. The endoscope has the wide angle view, so you have to see the both eustachian tube and openings. And of course, reduce as much as you can exposed areas, exposed bone or exposed mucosa. If you have a lot of bleeding, a lot of area of mucosa that is exposed, that is cut, you have to cover all those areas with mucosa in order to avoid or try to avoid the recurrence. I use sometimes the fibrin glue also to hold the flaps in position, which I think is a very nice way to do the surgery. Any evidence of advantage of using postoperative stents? I know there are many techniques that use the stents. I think the stents that they can be colonized by biofilms, and also the stents they can I would say not increase, but they can stimulate an overhealing of the area after you remove the stent, and then you can have a closure of the atresia that you opened. So I really don't like to use stents. And with this technique, the crossover technique, we don't need to use stents, and the results are very good and better than the series published with the stents. The paper is published, so you can PubMed is under Pignatari, the last name, Shirley, the crossover technique on choanal atresia, and you can see the results are very, very good. Another question is regarding bilateral choanal atresia, what is the incidence rate of stenosis? How many times you had to take patient back for debridement? Yes, this is a good question. Well, using this, the flaps for unilateral or bilateral, we got the same types of stenosis. It's about 4 to 5% of the cases that sometimes it raises stenosis a little bit, but just 1% of the cases we have to take back to the OR to do debridement. Because even sometimes if it stenosis a little bit, if we do a big opening from both sides and a good posterior septectomy, the air can go through and there will be no problems of secretions, of retained secretions in one side nasal cavity. It's going to drain to the other side using the posterior septectomy. So it's a very good technique. Role of mitomycin C, well, I don't use it because the mitomycin C is a solution that sometimes some doctors use to try to decrease this healing process and to not having closure again of the stenosis. But since we use the flaps, the mucosa flaps, they are very good, and you don't need to use mitomycin C to have good results when using the flaps. What about follow-up? For how long and what? You use medication after surgery. So medication is a normal medication, just like a normal sinus surgery, sometimes antibiotic, pain medicine for children, and some drops that the nurse can do of vasoconstriction for like 2 or 3 or 4 days. And the follow-up, we do usually within 1 month another endoscopy. We usually don't ask for CT scans after. If the endoscopy is good, no CTs, not to irradiate too much the children, the patient, which is very small children. So we rely most on endoscopy. This endoscopy can be done under ambulatory settings in the office, but sometimes the children does not allow you to do the endoscopy, and you have to sedate the children to do the endoscopy under sedation. But most of the times we can do the follow-up here at the office, and it's good. It's a good technique. What size of scope you are using? Any special techniques about patient position and approaching tiny nose by 2 surgeons? Yeah, this is a good question. First of all, I use the 3mm endoscope, the same endoscope that I use for ear surgery. It's 3mm in diameter and 14 centimeters in length. I don't like to use the 2.7mm endoscope, what they call the pediatrician endoscope, because I think it's more fragile and you don't have this wide angle view. So since nowadays we have this endoscopic ear surgery endoscope, 3mm one, I use this one in the nasal cavity because it is smaller than the 4mm and has the same image quality as the 4mm endoscope. We position the patient the same way we position for any traditional sinus surgery. Elevate a little bit the dorsum, hyperextend the head a little bit, and of course one surgeon stays in one side and the other surgeon stays in the other side. The key, the tip here is not to be sword fighting with your assistant whenever it's necessary. So sometimes you have to hold a little bit up your hands and then the assistant hold the hands a little bit down. But with practice, you can achieve. But most of the times, you do not need 2 hands. You can only do with one hand holding the endoscope and one hand with the instruments, because it's not a very... The challenging thing is the size. So if you use small endoscopes and if you use ear instruments, you will have size to do things that you need to do. Of course, you have to be more delicate. Sometimes, and it's not a criticism, but sometimes the rhinologic surgeons, they are more tough. They are more than the ear surgeons. When within ear surgery, you learn to have this fine-tuning thing, this delicate thing that you can also bring to sinus surgery. So you have to be very delicate. If you touch the mucosa, you can have bleeding. So don't touch demasively the mucosa. Use small instruments and position the patient just like you position in traditional sinus surgery. That is going to be very good. Regarding the fibrin glue usage, don't you fear it's dripping and blocking? Yes, this is a very important question, because if you use a lot of fibrin glue, the glue can solidify itself, and then you can have a very good bridge for the mucosa to grow again and then close again. So you have to be very careful after you put the glue, just to hold back the flaps. You have to see yourself with endoscope that it's completely open, the cavity. And when the cavity is open, and then you can put the Foley catheter if you want. But if you use a lot of fibrin glue, you can have this fear, and then you can have also problems with rare stenosis, because the fibrin glue, when it solidifies itself, can be like a conduit, can be like a bridge for the mucosa to grow back again and close back again the stenosis. What's the benefits of the Foley catheter? Well, for me, it's first of all to hold the flaps back in the position, because when the Foley is inflated, it holds the flap back and helps the flap to stay in place, because the children, when they wake up, sometimes they wake up crying. And sometimes if you do not use the fibrin glue, the flaps can dislocate with this crying and all this movement of the children. And with the Foley catheter, I think the flaps stays in the size when the children wake up or when they cries. And it's also a kind of a stent, but like that you remove 1 or 2 days after the surgery. So for me, these are the benefits of the Foley catheter. Did you encounter any eustachian tube dysfunction in those infants during your follow-up? Well, not at this time. Sometimes you have a lot of malformations associated. I have some patients that died of other disease, kidney disease or heart diseases. They died. But and other patients with ear malformations also. But I've never seen in my patients anyone with eustachian tube dysfunction. The muscles that controls the eustachian tube, they are functioning most of the times, and you don't mess with them during the surgery. So I think the surgery is not going also to create. Of course, if you cauterize a lot, or if you injure the region of the eustachian tube with scissors or with some other instruments, you can create scar tissues on the entrance of this, on the nasal entrance of the eustachian tube, and then you can have problems with the eustachian tube like that. But naturally, I've never encountered a patient with eustachian tube dysfunction. Have you encountered flap necrosis of this nasal septum mucoperius crossover flap? No, because the pediculation area is very big. It's not as small. It's like big in one side and then big in the other side. And this usually very vascularized area. The nasal floor is very well vascularized. And then the top part of the nasal septum is also very vascularized. So never encounter any kind of necrosis. But the flap has a big pedicle. It's not a small pedicle. And then you rotate. And when you rotate, you don't stenose the flap. You don't put pressure, a lot of pressure under the flap to get necrosis. Post-operative medication follow-up and protocol. I already answered. The medications are the same: antibiotics, pain medicine, and some drops of vasoconstriction. And the protocol is to do endoscopy 30 days after the surgery. And then if you need, you do other endoscopies after. But if 30 days is completely healed, you will just repeat the endoscopy if you need 1 year later or 2 years later, and no CTs. Most of the times, even if you need to reoperate the patient, we don't ask for a CT again because of the fear of the radiation and in small children. It's a cumulative radiation. Inverted Haddad flap, you use ever in your practice? No, but the flap, if you use a flap, it can be Haddad flap, pediculated superior, inferior, pediculated, the parallel flaps that Dr. Sedin used. I like the inverted Haddad flap. The flaps are very important to overcome the problems of stenosis, because if you use flaps with normal mucosa, you are reducing the area of cruent spaces, of area of possible scar tissue, of possible stenosis. So whatever flap you use, superior or inferior pediculated, posterior pediculated, anterior pediculated, you can use as long as you create a good space down there and you cover all the exposed bone and all the exposed mucosa, all the cut mucosa, in order to have less tissue that is more prone to have cicatrization. What do you do when you find mid-nasal stenosis along with choanal atresia? Do you treat choanal stenosis the same way as you do choanal atresia? Yes. Always opening and always covering with flaps. The nasal septum, you can generate different kinds of flaps from superior, from inferior, from posterior, from anterior. And the most important is to cover. Whenever you cut, especially in small children, to cover all these areas that you cut with normal mucosa in order to reduce the possibility of cicatrization or raised stenosis. So it's the same way we deal with choanal atresia. How do you deal with a pterygoid plate as a part of atretic plate? Well, down there, when you have the plates, the bone plates, you have to remove completely all the bone to create a good space. Of course, if you have a lot of pterygoid bone, of pterygoid plate, this usually is going to be more thick. This is one time that I might use the drill, because sometimes it's a little bit thick and then you cannot remove with a Harrison punch. But sometimes you can remove it with a chisel and a hammer. So this is a very important question. When you have more lateralized bone, as the bone goes lateral, sometimes it's more thick. And then you have to try to remove, to have a big opening to see both station tubes and to see the rhinopharynx. And if you cannot see, if you think there's a pterygoid plate part of this stenosis, you have to remove it. To remove it with a Harrison punch is difficult sometimes because it's a thick bone, but to remove it with a drill or to remove it with a chisel and hammer, it's possible and feasible. How to reduce or prevent bleeding in such a baby? Yes, this is the same way we do in the same sinus surgeries. You have to have a good anesthesia technique. Tiva anesthesia is very good for reducing bleeding. Adrenaline-soaked cottonoids, we use almost pure adrenaline in those cottonoids and put the cottonoids before we enter in the field. This is a whole lecture about how to reduce bleeding on endoscopic sinus or ear surgery. But basically, you have to talk to your anesthesiologist. You have to put those cottonoids like 5 minutes before the surgery. When you are dressing up or when you're putting the surgical fields, you can put the cottonoids and leave the cottonoids over there 5 minutes. And then after that, the mucosa is going to be very whitish, and infiltration sometimes is good. So bleeding is not a problem if you have good instruments, cutting instruments, because sometimes you have a good anesthesia, you put cottonoids, but you don't have cutting instruments. So you have to pass the same round knife 2-3 times. So, and then it's going to bleed more. Or if you don't have a cutting scissor, it's going to bleed more. So cutting instruments is very good, and good anesthesia techniques and good techniques overall for reducing bleeding on endoscopic sinus surgery. Do you need to take bone from lateral border? I mean the vertical plate of palatine bone. Yes, sometimes you do, but you can do with a drill or a chisel and a hammer. The important thing is at the end you have this view, very good view of the nasopharynx, and both eustachian tubes. If you cannot see the eustachian tubes, sometimes probably there is bone or mucosa in front. So you need to remove that bone in order to have a good exposure and a good view. Do you use the same technique for membranous, bony, and mixed? Yes, the same technique, flaps, same thing. And for me, it doesn't matter. Unilateral, bilateral, doesn't matter. Always the same flaps, and the results are very good. Any need for using intraoral 70-degree lens for monitoring the choanal? Well, I've seen that. I've never used it. I think it's a great view that you have because you can see from posterior to anterior in a very good way. But I think if you have a good view with the nasal cavity with a 0 or 30-degree endoscope of both orifices of the eustachian tube and the whole rhinopharynx, the 70 degrees more a good. It's a beautiful view, and I think it doesn't add anything for me to do differently during the surgery in order to open. It's a good view, it's a great view, but I've never used myself to guarantee that it's going to stay open. But it's a very good view. How long do you leave the Foley's catheter in place, and is only catheter enough? Yes, usually the catheter stays for 1 or 2 days because the balloon of the catheter, if you put saline solution, is going down because it's not completely sealed, 100% sealed. So in 1 or 2 days, it's already completely empty, the balloon, and then you can just pull the Foley catheter very delicate way. And yes, for me, only catheter is enough, and fibrin glue sometimes in the flaps. So it's no problem.
So thanks again, Professor Flavio, about the answering of the question. So most of this are repeated, and you already answered it. So excuse me, Professor Flavio, if you have a time to answer the other the rest of questions of our colleagues, we will be glad about that.
Flavio will be posted. So later on, when you have some time after relaxation, you can just take some few minutes in order to just review them, and you can post your answers. And thank you so much for your time and for your effort, and the greeting from every member in our group. And I hope the pandemic will settle down soon, and your next destination will be Egypt, because we are waiting for your travel documentary in Egypt. You will have a lot of scenes to see in Egypt, in Upper and Lower Egypt. So we are waiting for you there, and we hope that you will be the first group to meet you in Egypt.
Yes, I hope so. And have a nice Ramadan. I know you are under Ramadan.
Yes.
And inshallah, I can be in Egypt someday. And assalamu alaikum.
Sure, you will be welcome.
Wa alaikum assalam wa rahmatullahi wa barakatuh. Thank you.
Thanks. Thank you.
Thank you.
Okay, bye-bye.
Bye-bye.